All right. Well, let's go ahead and get started here. Welcome everyone to yet another segment of our education series. Today is dressing selection webinar entitled The Right Dressing, the Right Time, How to Choose with Confidence. So as always, thank you for taking the time to join, especially around your lunchtime. My name is Johanna Welch. I am Assistant Director of Clinical Services for ProHealth One and will be one of the panelists for today's webinar. Just a quick note before we do get started. Please use the question and answer box to ask any questions during the presentation. And then also, we do have polling questions throughout the webinar today. And in order to get the credit for the continuing education hour, please make sure to respond to all polling questions. Okay? So, without further ado, I would like to introduce our speaker today. Today, we have Dr. Kevin Penn. Dr. Penn is a wound care physician with ProHealth One, and I will pass it over to him.
Well, welcome everybody. I I'm excited to talk to you about dressing selection. It's something that if you've ever rounded with me, you've probably heard a fair amount about already. But it makes up the bulk of everything that we do. So it's near and dear to I think all of our hearts. So um, moving forward, just a few disclaimers. Obviously, the information provided here is for general information purposes only. Remember that this is an information session. It does not contain or present specific medical advice. Health information is provided for general information and education only purposes and is not a substitute for professional health advice. Before taking any actions on this such information, we encourage you to consult with appropriate medical and healthcare professionals and use these and use and rely on my information at your own risk. Now, also, as a side, I am not affiliated either myself or as ProHealth One associated with any dressing maker. You don't have any financial ties to anyone that produces or sells dressing supplies of any kind. So no disclosures there. I will say there are some pictures throughout. These are just generic pictures, representative and not specific recommendations for any case. So kind of moving forward there. So I'll give this over back to Joe to if we need to check in and make sure we're okay here.
All right, the quick first polling question. When selecting a wound dressing, how confident do you feel matching the right product to the wound type and condition? So, first one is not confident, usually need guidance before making a selection. Second choice, somewhat confident. I know the basics, but second guess myself often. Third choice, confident. I can typically select the right dressing independently. Or fourth is very confident. I feel comfortable educating others on dressing selections. We'll give you guys a second to answer that before moving on. All right, and the results are in. Looks like most people are saying they are somewhat confident with 56%. Second biggest is confident with 22%. So back to you, Dr.
Okay.
Penn.
Okay. So as we talk about these things today, wanted to set out some objectives. And for me, it's always easier to start off with systems. So we want to make a system by which we can identify the components of the wound, but also how we're going to identify which aspects are important to us. So let's come up with a system first. Then once we can identify the system based on the wound, to be able to select an appropriate dressing. Once we get the appropriate dressings, hopefully build the confidence through a couple of key cases at the end to try and build that confidence out with dressing selection. Caveats to that is there are there are thousands of products on the market, and there are some that I have never heard of, and we won't cover all of those. This is also is not comprehensive in that we don't know. Every wound is an experiment in some cases, where there are different compounding underlying factors, where there's different health scenarios and complications, and then also each wound is at a different place in its healing rate progress when it gets to us. And then ultimately, I won't be giving specific advice on specific products, specific brands or any of that nature. So these are more specific, generic advice over categories and classifications of dressings. Okay. As we go through these things, there is a little bit of there's a little bit of a caveat with this, because we're talking about dressing selection, but ultimately dressing selection are orders. And just like you wouldn't substitute someone's blood pressure medications or their insulin without an order, the same is true for dressing selections. The scope of practice is, if you're not an individually licensed provider, then randomly changing these within the week is not within the scope of practice for most nurses and nurse practitioners, or outside of like nurse practitioners, PAs, or physicians. Also, when a dressing is ordered, we have to update our documentation. So if we're changing the orders, if you do obtain an order throughout the week between rounds, we do have to update the orders to reflect what's actually happening, and that we have to do the thing that the order says. So, so as we talk about those things, the question, before we get too far, I do want to say that, so then why even talk about it? Why are you talking about dressing selection to people, or in a setting where a large portion of the people who are here aren't going to be the ones that actually make the orders or make the final decisions? And I will take just a second off of slides to express a little bit of gratitude, because in this, so often, for example, if I round every week in a skilled facility or in a long-term care facility, my eyes are on that patient for 10, 15 minutes. And so by identifying these kind of systematic approaches to dressing selections, our hope is that even when we're not in the building, you who can be our eyes, our ears, everything in that building, to identify when there are problems, to identify when there are challenges, maybe alternative needs that these individual patients have, so that you can have that confidence to be those eyes and ears. They say that the conductor of an orchestra never makes any sound, but he relies on those around him for all their power. In the same way, for most of us as physicians, that we rely on individual nurses at the bedside, individual, LPNs, RNs, CNAs to help us to make real change in the lives of these patients. So appreciate all that you do, and hopefully that we can empower you to make those changes and work together. So as we go forward, this is a lunch and learn. There are some graphic photos ahead. Although if you've chosen to be here and listen to me talk, you're probably going to be just fine, but I wanted to give you a warning just in case an administrator hopped on for some reason. So this is a normal algorithm that we talk about. I think most of us, especially if you've been to previous educational seminars with us, you've heard this framework. Most of the time it comes with we talk about with time or DIME or other similar things, but it's just a way to assess the wound. And again, when we talk about this, we talk about systems, right? The system makes it easy, kind of puts in the algorithm. We do this in an operating room with a timeout. We do this with many parts of healthcare. And that systematic approach helps us to make sure that we're not missing anything, and make sure that we have consistent outcomes and consistent assessments. And so when we're doing that, we're going to start with the tissue. Now, so this is the tissue of the wound itself. So what's happening? What's going on with that wound? Is it combined viable? Is there non-viable tissue? Those main things that we're going to talk about are things like granulation, slough, eschar, epithelial tissue, biofilm, those things, what's happening right in the wound itself. This comes first because it's the most important. We go down to the eye, and in the eye, we were going to assess for infection. The other thing we can talk about is inflammation, because if it's not reaching the point of infection, maybe the wound is inflamed or critically colonized. We take this, and I'll just take a second to kind of remind ourselves of this of the spectrum of contamination and infection. Now, a wound that's created in a surgical setting is clean, and it's created if I'm cutting it under sterile conditions, that's a clean wound. But after about 24 hours, the wound becomes colonized. That means the bacteria from the surrounding skin go into that wound, and unless it's sutured closed or glued closed, you're no longer in a sterile environment. So, more so with wounds that are larger, chronic, or we estimate that they'll take longer than 30 days. Those wounds are immediately colonized, starting from within 24 hours after creation, or sometimes when they're created in a dirty way or in a dirty environment, those are immediately contaminated. So when we talk about colonized, it just means there are bacteria that are present on the wound. Now, if we make that and take that to the next step, okay, well, it's colonized. So most wounds are going to be colonized. Basically, all wounds are going to be colonized in our setting. So then when we are making this assessment, or does that mean they're infected? And the answer is obviously no. So, but we take this kind of spectrum and we go from clean to colonized, and then we are going to go into something called critical contamination or critical colonization, where the bacteria are starting to cause a problem. We'll see that with biofilm. So not only is there bacteria on the surface, but the bacteria that's on the surface is causing a problem and inhibiting wound healing. And so that colonization is now causing a problem. So we call that colonized, going to critical colonized. And once those bacteria get out of the wound and into the surrounding tissue, that's when we would call things infected. So colonized, the bacteria are there on the surface of the wound. Critical colonization, those bacteria are causing problems, usually in the form of biofilms. And then when we go from there, we go to infection. Now, infection is to the surrounding tissue. Now, and then once you're into infection, you can go on to the things like sepsis or bacteremia. And that's, again, not within the scope of what we're talking about. So when we look at that infection, or when we look at the eye, we look, okay, is this colonized? Is this critical colonization? Is this infected? The other part of that is that notice that there's that part of infection is also should be inflammation, meaning the wound is inflamed. There is localized inflammation to that wound, and not all that is inflamed is infected. We'll talk about it in a second. Moisturize, and going to the M, we're going to moisture balance. We don't want this too wet or too dry. I know any of us who have spent any time with patients for any prolonged period of time have heard, yeah, just let it dry out, or don't even need to cover that one. But we'll talk about kind of why that's important. And then looking at the edges of the wound. So with the tissue, we're looking at the wound itself. And then with the E or the edges, we're going to look for what else is happening in that wound. It helps us give an overall picture of what's happening in that wound. And as we move forward with the edges, to try and understand, okay, well, what's impairing the tissue from becoming the wound edges. So we'll talk about epibole, callus, and then the peri-wound integrity. So kind of moving forward with there. So like I said, we're talking about tissue. I won't torture you with my Latin, but the Latin phrase is, if there is pus, get it out. And obviously the Latins were talking about pus in a very general sense. But the thing that you, as the person that's evaluating these wounds, should be focusing on is really kind of a dichotomy. Is there non-viable tissue in the wound bed or not? Because if there is non-viable tissue, then your body won't heal over it. We have signals within our body, things like matrix metalloproteases, that inhibit wound growth when there is non-viable tissue. That's a normal part of our healing. That as long as we have that non-viable tissue, your body does not want to heal over that, which is appropriate. So that acts almost caustic to healing. We think about it as a weed barrier almost. So where you put down the weed barrier, the weeds won't grow. where you put down the biofilm or slough or other non-viable tissue, that is toxic to growth and granulation tissue. So the biofilm in and of itself can just disrupt healing and limit our healing potential. And so in order to get rid of that, our body has to go little by little to break down that barrier, which can be a significant impediment, especially in a lot of our patients where wound healing is delayed anyway, with all the other comorbidities. So addressing this primary issue is kind of the biggest thing that we have to start off with. So that's why it's first is, and even if we don't have even if we don't have like a specific, like what's biofilm, what's slough, it doesn't really matter, right? Ultimately, the answer is it's got to come out somehow. So in a lot of these wounds, there will be times where there is some combination of both of those, slough versus biofilm. It's rarely completely straightforward, but those things, regardless, have to come out. So what are our options now? Obviously, the preferred mechanism of a wound care physician is a surgical debridement. It's easier. It allows us to immediately debulk that area, but we're going to talk about some other areas as well. So mechanical debridement, enzymatic debridement, biological debridement. We won't really talk about biological debridement, although it seems that I can't go a week without somebody asking or telling me, whether a patient or otherwise, about maggot therapy and how they'd like to try it. But for the purpose of this, that's just going to be no-go. And then autolytic, and then we'll talk about some special considerations. So again, remember the sharp surgical debridement. It allows us to do the most rapid debulking of the area. Again, these are often necessary, but they obviously have to wait. Mechanical debridement, this is where kind of your hands and eyes come in. It should be part of every physician or every wound change. We're just cleaning the wound. Now, this does not have to be, you don't have to completely scrape it out. No Brillo pads are necessary. Just clean gauze to try and break up any of the mechanical biofilm or slough, any of that. Just the act of cleaning the wound is powerful as a first line for mechanical debridement. The nice thing is, again, that this can be repeated throughout the week. Every time you do the dressing change, it doesn't require an independent license. So that's the nice thing. Enzymatic. Most of the time, we're talking about a product like collagenase or Santyl. Santyl is really nice because it is not painful in any way. So for patients who have sensitive or sensitive wounds or very painful wounds, they can be used. It is an end collagenase, so that means if I imagine the collagenase is like a Pac-Man, the collagenases work either, they call them side collagenases, and they can snip basically through intact collagen, or end collagenases, which means they require a free end or a loose end of collagen for it to be able to chomp down those little protein pieces. And so the nice thing about Santyl is that you can put it over tendon or muscle or healthy intact tissue otherwise, and it won't have access to the ends of the collagen, so it can't do any damage. But anywhere where there's loose collagen, which would happen in the setting of necrosis or injury, then the Santyl can do that. The other problems are with it's expensive. It requires a specific prescription. Most of the time, facilities don't have it. It's usually used as a last case scenario or very in special circumstances, which can be present, but it's kind of a last resort because of the cost and because of the difficulty obtaining it. Biologic, again, these are maggots. Again, you're going to hear about them, I'm sure. If you haven't already, at some point in your career, you'll have a facility or a family or somebody asking if but in 9 years as a physician, I've never seen it, and hopefully we'll never see it intentionally. I hope never to see it intentionally. And then we'll move on to something, again, just like mechanical, where this is something within the wheelhouse of an everyday kind of wound care nurse that's in the facility seeing these patients on a regular basis. So for this, we're going to talk about autolytic. Now, autolytic is what your body is already doing. So if we were to take slough, the slough is attached to our body through the normal kind of proteins. They're protein attachments. They're the kind of like individual anchors that tie the normal tissue when it was healthy into that area. So there's things like hemidesmosomes and desmosomes that are literal protein attachments that zipper the thing together, that act like sutures to keep the intact tissue there. Unfortunately, as the tissue dies, that unless there's significant, controlled cell death, those attachments still are there. Those proteins still hang around. And so for our body, we need to have basically come in with our white blood cells to come in and clip those individual attachment points. What that does is, so in order for that to happen, we need to have a moisture balance. White blood cells can't travel through dry spaces. That moisture acts as a road for white blood cells like macrophages and natural killer cells and things like that to come in, initiate apoptosis, the programmed cell death, and eat up those proteins and basically snip the attachments of all that dead tissue. And that has to come in one by one. So in order for us to basically to be able to do that, to have our white blood cells going in there, we have to encourage a moist wound environment. This is more effective on necrotic tissue where there's normal highways go, as the normal kind of blood flow would have happened anyway. So it is more effective in slough and necrotic tissue than it is in biofilm. That's just because the biofilm doesn't have blood penetration into it, and so that can take a little bit longer for our white blood cells to fight things like biofilm. Now, the reason I bring this up is because this is basically where we're going to do for most wounds anyway. So in addition to the other things, we're going to be encouraging autolytic debridement. Why? Because it's the normal natural process. It augments the other types of debridement. And that's why it's important as we look to all of our other points about, like, especially with moisture balance, autolytic debridement is the basis for what we're doing. Okay, so that's the great part for us, is that this one's free, and the body's already doing it. The thing to note though is that for people who are immunocompromised or who are on drugs that cause immunosuppression, this autolytic debridement can be impaired. It's also impaired where there's limited blood flow. Which we'll talk about at the end, but just as a heads up, the next one of these will have peripheral arterial disease. And one of the reasons that autolytic debridement is impaired is because if there's no blood flow in that area, you can't get white blood cells to do this autolytic debridement. So think about this autolytic debridement as the baseline option, but can be impaired in certain circumstances. Okay. So going back to the eye, so that was our tissue, talking about debridement, what options we have. So that's time. So let's go TI. We're going to go into the infection or inflammation. So remember, we talked about this a little bit already, but that in this wound, for example, that if it's clean, contaminated, or colonized, critical colonized, and then infected. So many times we will get areas where there is inflammation, which is a normal and natural process. Remember that inflammation is where we go to autolytic. Autolytic debridement happens because there's inflammation of the wound. If you don't get some amount of peri-wound inflammation, you're probably not going to encourage autolytic debridement. So to take a step back and say, okay, well, is the wound inflamed? Well, I hope so, because then we can have some autolytic debridement. That's the natural healing process. As we go from the inflammatory stage of wound healing to the proliferative phase, all of that requires that inflammation first. And so is there inflammation within the wound bed? Okay, great. So then recognizing that that's there. So not all that is red is infected. So oftentimes the well-meaning providers will look at a wound and think, oh man, that's infected. It must be infected because there's redness around it. That's oftentimes not true. And most of the time, we see that the inflammation is the primary cause there, not necessarily that it is infected. So, kind of taking that step back, it's our assessment now: is this wound contaminated or colonized? Is there something on the surface? Okay, probably. Now the next step is that colonization causing a problem? Meaning, is it causing that biofilm? Is that biofilm impairing wound healing, especially in chronic wounds? Is that happening? And then as we move to kind of forward from there, is that moving into the surrounding tissue causing infection? Now, once you get into that kind of deciding point, this is where you're probably going to need some assistance, both for recognizing that infection, just because it can be subtle. And the other part of that is once you get to that infected, you're going to need help with other orders like antibiotics, either locally or topically or systemically, or we would call them bidirectional, meaning you put some on top and some in the PO setting. So this one isn't as straightforward, but remember that there is that kind of spectrum, and that not all that is redness means that it's infected. So trying to decide between those two can be tricky, between what's just inflamed and what's infected. A couple of things to mark is when you start to see the redness spreading from the wound to other places. So not just localized erythema, but that erythema that starts to migrate, erythema that starts to track, or when you start to see kind of signs of concern, such as your drainage is going up, your odor is starting to develop, there is more pain with the wound. Any of those things can be markers for infection, and it should be a sign to us that we need to move forward with those kind of direct antimicrobials or antibiotics. So moisture balance. Now, again, we're going to talk a little bit about this as we get to the dressing selections, and we already talked a little bit about it with autolytic debridement, but this is, let me see, I think we got here the Goldilocks principle. I'll get back to our last slide, but with the Goldilocks principle, we want to know, okay, the story of Goldilocks is that this is too hot, this is too dry, this is too hot, this is too cold, this is just right. And the same principle is here, is that we do not want, obviously, significant moisture, because that can be a setting for infection. But also, if our wound is too dry, it won't heal. So you can't get the inflammatory cascade. So we can't get things like autolytic debridement. We can't get things like proliferation. So our goal is to manage it just right. So this is an example of obviously something that is very, very wet. That's way too wet. You can tell by the skin tones that are there that this is too much. Some examples of this: arterial wounds, they tend to be on the dry side, again, because there's not blood flow there. So if there's no blood flow, that the serum you can't convert that into drainage. And then venous wounds tend to have higher drainage, and that colonization or critical colonization or infection can lead to increased drainage. So just some things to think about as we talk about moisture balance. Then we're going to talk about the wound edge. Now, with the wound edge, and we sometimes can get focused on the hole, if you will, but rather the things around it can often play a significant role in how they get better. Because remember that our granulation is happening, our proliferation happens in two ways. One is you have fibroblasts that fill the hole in, and then we have things like myofibroblasts, which pull from the outside in. And if our wound edges are healthy, things like myofibroblast can't pull from the outside. So we can't pull or contract that wound together. So we're limiting the amount that we can heal. If our edges aren't healthy, then we're not healthy. The wound isn't going to heal. So peri-wound concerns, like we talk about, like friable skin, macerated skin. One of the things we'll talk about is that as well is that epibole. So you can see some of that happening in the picture here, is some of that where the edges are starting to roll. Now with the rolling, again, we don't have to get too much into it, but this can impede our improvement. So this is an example of a callus. So when this callus can be both individually, but also these can occur around wounds themselves. And in order to facilitate actual healing there, the callus is just excised locally. Now, unfortunately, you guys don't get to do this, but let me tell you, one of my favorite things is just getting to take all that extra callus off, either the peri-wound or the bottom. So let's take a step back. And we've gone through the time, right? So we've gone through the tissue. We talked about the infection or inflammation, talked about moisture balances and wound edges. And so this is our way of coming up with a systematic approach to dressing changes. And the reason, again, is that it helps me to come up with a systematic way to look at the wound. And when I'm doing that, I like to put together a sentence. And if you will, to do, I think most people, even if you haven't been in the hospital setting to see residents or present to attendings, have seen it on Grey's Anatomy or whatever show floats your boat. And to come up with like a one sentence or two sentences to describe a wound. So this is the example. So looking at a wound, we'll say, okay, what's causing this? Okay, so this is a chronic wound or an acute wound. This is a chronic. So the example is there's a chronic wound due to arterial insufficiency. It's too dry and it has a biofilm. And what that's doing is trying to prime ourselves, trying to give ourselves a system to try and encapsulate what is almost certainly a very difficult patient, or a complex patient, I should say, not difficult, but complex, and a complex wound. Okay, so we can say, okay, this is a chronic wound due to arterial insufficiency. So the same thing can be true if you're looking at a wound and trying to communicate this with a provider to suggest, hey, Dr. So-and-so, or, nurse practitioner, hey, we have a 77-year-old gentleman with a diabetic foot injury that is contaminated but not infected. It's chronic in nature. It's too dry. And I think that it has a biofilm. And we can put that together to communicate effectively, either between nurses or, again, like communicating with a provider to try and help us understand what's going on. So I think taking this as an opportunity, or taking a step back to try and practice that, can be helpful when you're saying, man, I don't even know where to start. And so I recommend that to our providers. I also recommend it to each of us as we're trying to come up with those dressing changes. Okay, so we've got our picture. So we've got an understanding. We've used the time to put together an understanding of a kind of a encapsulated picture of what's happening here. And then once we have that, okay, now what do we do about it? And that's where we're going to go to next. So again, the questions that we're going to ask is, okay, what are the modifiable factors here, right? Like, what are the things that we can change? What from that time, or that TIME, what, based on our one sentence presentation or two sentence presentation, what are we going to do about it now? And so that's where we start to talk about things like moisture balance, because that's the easiest thing that we can start to do. Because again, that moisture balance is going to affect one, proliferation, and also it's going to affect whether we can do whether we can get autolytic debridement. So going forward. So is it wet or too dry? Is it moisture balance? Is the wound balance good enough for healing? Is there debridement necessary? So do we need to be talking to surgeons or providers for sharp debridement? How do we do do we need to change things to promote autolytic debridement, or enzymatic debridement is necessary? And then what do you have as your options? And this is where I think your part is to say that what's on your formulary at your institution, where you're at, what do you have? Because do you have lots of silver alginate or alginates? Do those look like exoderms or aquacels or whatever those things are? Become familiar with it. And for me, I always recommend just going into your dressing supplies and go, okay, what do we have? Or even talk to your supplier, whoever orders for you, and ask from them. Okay. So I'm going to go give some time to Joe.
Alrighty, question number 2. What is your biggest barrier when it comes to wound dressing changes at your facility? So, not having the right supplies or products on hand, limited time during my shift to complete changes properly, inconsistent communication or documentation between staff, uncertainty about which dressing to use and when to change it, and lastly, getting physician or provider orders in a timely manner. Everybody get your questions in or answers in? All right, biggest answer, largest answer here is not having the right supplies or products on hand, Dr. Penn.
Okay. Well, let's go through this just to keep this so we're on the same page. Primary dressing, this is the thing that touches the patient. So when I talk about primary dressings, it's the first thing you put on there. And aside from skin prep, what do you put onto the wounds? Generally, it should be cut to fit. And then secondary dressings, things that go on top that are going to help keep it in place. There's also retention, like things like ACE wraps or roll gauzes and things of that nature. So first step, like kind of working here, we've got, so from a peri-wound protection status, protecting the peri-wound, these are creams or skin preps. Then to the wound itself, cutting the primary to fit. And then the secondary for drainage or moisture management. So again, kind of talking about this, remember when we say the primary, that's the thing that touches the wound bed, should only be touching the wound bed. Secondary is the thing that can be touching the peri-wound skin or other things. That's the stuff that usually helps with managing and retaining or absorbing or dressing or drainage. And then 3 is the stuff that keeps it in place. So when the wound is, so getting back to our time, with when the wound is wet, but only a little so, one of our recommendations is to just use things like collagen. Collagen is an effective protein-based dressing. It helps encourage wound healing with some complicated things through inhibition of what we call TIMPs or tissue inhibitory metalloproteases. And then the secondary, so you can use things like collagen, especially when all we're dealing with is moisture. And then we go for the secondary. The secondary to increase the absorption of our secondary dressing. When you're talking about a moderate amount of drainage that we need to manage, there's a couple of these that are all that we have options. These are the primary things that we have. So alginates, hydrofibers, so methylene blue-based foams. So those are like RTD or hydropheric blue or Gentle blue or any of those things. And then also iodosorb. Now, iodosorb is a cream that's a slow-release paste. And then the secondaries, we can rely on things like super absorbents, foams, or even simple ABD pads. Some of these, remember now, that part of this, some of these have an adhesive on the face of them, so be cautious around patients with frail skin. And then also having a variant level, once they're moisture, once they become wet, they can become adhered to the wound bed themselves. And when you're deciding these, whether so Opticell or so hydrofibers or alginates or any of that, one of the biggest things is availability, what you have available in your facility. Now, remember again that making substitutions, if those should be written as a generic, and we try to beat that into the providers. But if it says something specific, you need to get an order if you're going to change those things. So if it says Aquacell, just contact your provider to help it if that's not available. And then for our patients where they're not responding to just that primary dressing and their secondaries are tough, the biggest and easiest thing is just to change the dressing more frequently. Now, there are some things that you can use like Eclipse boots and Optilocks or Optipads or Hydrolocks or any of those things. Those can be very helpful, but also very expensive. So when in doubt, change the dressing more frequently, especially since most providers will put in a PRN order. You don't need to modify them. You can just change the frequency there. So if they say daily plus PRN, you can provide additional dressings without getting another order. So that's something as an initiative that you can do, and to be responding when the moisture is too much. And that includes for moderate amount as well. So if it's overwhelming the dressing, move on. Moving back to the other side of things is when it's too dry, we can use humectants. So primary humectants are things like hydrogel. They can use hydrocolloids and honey-based gels. So we getting on to what a primary versus secondary. Now this is a little confusing. When we talk about primary versus secondary dressings, we're talking about the things that are touching or not touching the patient. When we get into humectants, this is a little bit different. Primary humectants are gels or ointments, and when you put in 5 milliliters of moisture, that's how much you're going to get. Whereas secondary humectants, basically the honey-based gels, rely on an inflammatory, and you put in 5, you get 25 back. It relies on your ability to have blood flow to that area. It relies on your ability to have inflammatory response there. So considering with the humectant therapy, primary humectants are more controlled, but they have to be applied generally daily. Secondary humectants have to have contacts deeper in the wound, but can be nicer for patients where you don't want to change the dressing every day. The one caveat is that if you're using a honey-based gel, that you can lead to hypergranulation, which can become a problem. We're going to go to special considerations. So again, the peri-wound, remember the E part of that, is that when we're talking about the peri-wound, you can either do it with a spray or a wipe, like there's Cavalon or the SurePrep or any of those things. Or if we can do the barrier creams, zinc, antifungal, triad, any of those can be very effective for the peri-wound. They can limit adhesion. So if you're relying on a bordered gauze dressing, just be cautious with your barrier creams, because otherwise your dressing is going to come off before you leave the room, and that's always frustrating. The other is the tapes, and various tapes. If you're using something like an EVD or a non-adhesive dressing, remember you have a variety of tapes and things that you can add to the set there. Now, one thing I will say is that this is something that's used, is that wet to dries almost are never dry by the time you pull them off. It's almost always wet to moist or moist to moist. And really think about these as a transition. They're only there for shortened period of times or for special cases when you're trying to get to something else. So things like Bosch or Dakins can be effective, but only in limited spurts. And also they should be a transitionary, a bridge to something else. So these are considered subpar. We have heard instances where this has caused problems with state inspections, so something to be aware of. So now another consideration is, we talked about epibole before, but when there is wound depth, in order for your body to heal that area, it has to heal bottom in, side, or bottom up, sides in. In order for that to be encouraged, we have to fill that depth in. That needs to be some sort of packing strip, or roll gauze, or the alginates, the hydroferrous, any of those things that have a bulk to them need to be kind of placed in the wound so that the wound edges don't fall, and it prevents that kind of epibole from forming. So that would go for both undermining and tunneling, but also just significant wound depths. Negative pressure therapy can also be utilized, but again, don't initiate that one without talking to the provider. The next thing I will say is that contact layers are, I think, underutilized in our space. I think that, so this is one where you're going to remove a contact layer is going on the surface of the wound as a primary, and allowing things to do so as the dressing changes to remove pain as part of it. Now, these vary based on how permeable they are to water or air, and so they can be occlusive, especially if used incorrectly. So they can contain different things like antibiotics or antiseptics, or some of the newer versions actually have like a detergent or a surfactant in them. Some of them have, like the Versatile shown here, can stay up to 7 days. But again, those are kind of special cases. But if you're finding pain is a limiting factor with your changes, this is something to think about. Okay, so we're going to go through make our 1 sense model. We're going to use the last 15 or 13 to 15 minutes to go over this. And we're going to go from here. So with our moisture control. So this is a patient with a diabetic foot ulcer of their right medial dorsal foot with 100% granulation, heavy serous drainage, and macerated callus to the periwound. So which of the following are you likely to pick? Again, I'm going to go over this. There's a right dorsal foot with a diabetic ulcer, 100% granulation, heavy serous, macerated callus. Joe, what you want to help?
You'll just say them out actually,
Okay,
and
great.
then
That's
kind of
fine.
explain what you're going to be picking and why.
Okay, great. I
Mhm.
don't know if you wanted to.
We don't
That's
have
fine.
pop-ups for this one, but thank you.
That's it. So Hydrofera, Hydrofera Blue, Iodosorb, collagen, honey-based gel. Okay. So I'm going to walk through this. First, I'm going to eliminate the things that we've said that this is heavy serous drainage. So things like collagen are out, and same thing with honey-based gel. That's a humectant, so we can't do those. The next part we could do is Iodosorb versus Hydrofera Blue. Now the limitations on these are going to be mostly the formulary. Hydrofera Blue, if it can be cut to fit, so if we trust the nurses that aren't going to be there when you're not there, if we can really get a good cut to fit, then Hydrofera Blue would be totally appropriate for a moderate to heavy amount of drainage. Iodosorb would also be easy to place, but can be difficult because of cost concerns, because oftentimes Iodosorb is not on the formulary. I would love it to be on more formularies, but sometimes that is not. So, and if it were me picking this, it would be based on formulary, but more than likely it would be Hydrofera Blue cut to fit as a primary dressing. Okay, so we're going to take a step back again to another wound. This is a coccyx pressure injury, stage 4. So we have a stage 4 pressure injury of the coccyx. It has 70% granulation and 30% slough. There's moderate serous drainage, and the periwound is denuded, macerated, and there is a pibbilling noted at the wound edge. Okay, so what are we going to do next? Now, I'm not going to go through all the dressing changes, but what would we do to protect this? Okay, so looking at this, how are we going to help this periwound, this poor periwound? Going over this, it kind of depends on the secondary that we'll use. So first of all, betadine to the periwound, probably not ideal in this situation because it can further dry that wound out, causing cracking of the skin. And alcohol wipes, you probably would only use once before your patient was very unhappy with you. So we move over to what B and D, barrier cream and skin prep. It would depend on whether we have an adhesive dressing or not. If we're using an adhesive foam, then we may not be able to use barrier cream. If we were able to use something with a wider, like a wider foam or a wider super absorbent, we could use barrier cream. But if we can't get that to stick, then ultimately skin prep. Skin prep is never a bad idea in this case. If we can't get the barrier cream to work, especially something like an antifungal barrier cream for this one, then I'm going to move to the skin prep. So arterial dressings, this is a first and second toe of the left foot. It's arterial in nature. The tissue is 100% eschar. There's no drainage, and the periwound is intact, but obviously impaired. Moving forward, okay, this is we haven't really talked about this, but the one thing that we would talk about, or one thing to mention on this, is that as long as the eschar is stable and intact, we try to leave it intact as much as possible. So hydrogels and oil emulsions would promote a more moist wound environment, but that would also start causing debridement when we want to keep those intact. So in this case, you could either use skin prep or betadine. There's preference involved with this, but personally, I use anywhere below the knee with an intact eschar. Recommend that betadine just be used at least once a day to about 2 centimeters to the periwound. So we betadine. And when you write it, I always write just paint with betadine. Don't just place the betadine. Paint it like a kid with finger paint. So just get it all over the place. We're going to go to another type of wound. left posterior calf, venous ulcer. It's got 25% granulation, 75% slough, moderate serous drainage, periwound is variable, macerated, and there's edema. So again, if we take back what's causing this to not work, just before we even look at dressing selections, what's not working about this? Well, the drainage is too high, probably. There is some slough and some biofilm in this. So that we need to be answering those questions as we choose our dressing selection. Soil emulsion could be used. More than likely, that would address the pain issue, but with oil emulsion and alginate, that might be a little bit more tough, just because the oil emulsion can retain some of that. For honey-based gels, that's a humectant therapy that's going to promote granulation or hypergranulation, or it's going to promote drainage, I should say, more than important. For C, Xeroform, Xeroform again is a contact layer. Love the thought of the contact layer, but with Xeroform, it can retain some of the moisture and can be an impedance there. And so ultimately, out of these choices, if it's got a moderate amount of drainage, there's some biofilm, it's a contaminated wound, so I would start to move towards a HydroFerroBlue or similar. So whatever version of HydroFerroBlue you have with your facility. I'm just reminded how many of you got left. Okay, Sacrococcus, stage 4, some slough, some mostly granulation. Our biggest concern is the periwound with fungal, friable, and there's some epiphyly. So remember that this is a heavy amount of drainage. We've probably seen this patient before. Their periwound is very impaired. And so we start to have to ask those questions. And in the meantime, obviously this would be a candidate for negative therapy, negative pressure therapy. But in the meantime, we can use things like we need to make sure that this is packed. So hydrocolloids could protect the periwound. Alginates, again, could be a answer, but they would take a lot of alginates to appropriately pack this. Before we can get a negative pressure, Dakin's moistened Pearlex could be a temporary. Again, remember, this is just a temporizing measure. And then ultimately, I think we're going to need a negative wound pressure or negative pressure therapy. Another kind of one of our last ones here, this is we've got a heel and I believe a buttock, both with 100% slough. There's some periwound inflammation as a prior, with no evidence of epiphyly at this point. So if we're going to pick this, we're going to have to address first the primary cause. What's the major concern here? And that is debridement, right? We all know there's non-viable tissue. The wound's not going to heal this way. So how do we get it out? Biologic. Hopefully no one's picking biologic. You can do surgical, autolytic, or both surgical and autolytic. The nice thing is that we can start with the autolytic even before the provider gets there, kind of being able to provide that moist wound balance, and then move to surgical when available. Okay. Joe, I got you.
All righty. Yeah, last question. We're going to leave this one open-ended for you guys to type in your answer. What wound care topic would you like to learn more about next? If you type this in, it will help us plan your future education. I'll give you a second to type in whatever you want. And also just a reminder, if anybody has any questions, to go ahead and try to put them into the Q&A boxes. And back to you, Dr. Penn.
So just while I'm waiting for any questions that happen, just a reminder again, in June, we'll have our next educational session. Dr. Rye and Dr. Dragans will be talking to us about peripheral arterial disease. And if there are any other questions, let me know.
All right. I am not seeing, let's take a look at the Q&A here. No open questions. No, I'm not seeing any questions. We can leave it on for one more minute or so if you want and then drop
Yeah.
off.
I
Okay.
just again express appreciation that that we, as we look at this stuff, it's something I'm excited about, something I think we're all passionate about. It's one area of medicine where we're getting to see real changes in people's lives, functional changes. You don't get to see, when diabetes gets better most of the time, but you do get to see when a wound gets better. So I appreciate the eyes and ears and the ability to make us look good when you're doing the hard parts. And so we appreciate the day to day, the ins and the outs, all the things that you do. So
All right. Not seeing any more. So yes, thank you so much, Dr. Penn, for presenting for us today. And we will see you all on the next one for the peripheral artery disease.
thanks, Joe.